Bi means two, poles means ends, and affective means mood. Then it is the illness, it is the mood illness or mood disorder which is having two ends. One end is the mania, and the another end is the depressive disorder. Yesterday I talked about the depressive illness, depressive episode, or depressive disorder, in which I told that depression is a mood which we all of us experience time to time, usually due to some distressing circumstances. But it is considered a disorder when it is out of proportional to the loss, or when it is abnormally prolonged, remaining 2 weeks or more, and it was characterized by the depressed mood, lack of interest and energy, remaining for more than 2 weeks. But today we are concerned with the mania. And if someone is having relapsing and remitting episodes of mania and depression, then it is considered as a bipolar affective disorder. And if you go to the definition of bipolar affective disorder, then it is the mood disorder that causes the unusual shift in mood, energy, activity level, and the ability to carry out the day to day tasks. And if we go to the criteria of mania, how you are going to label a person, and what is the time duration for those symptoms, is I told about the depressive disorder, depressed mood, lack of interest and energy, remaining more than 2 weeks. But in the mania, the duration is shorter to make the diagnosis of mania. Um, the duration is of, if someone is having disturbance of the mood, which is so aggressive or so violent that the hospitalization is necessary, then the person can be diagnosed even he is having symptoms for 2 or 3 days. Otherwise, the symptoms remaining at least for 1 week is sufficient to make the diagnosis of mania. And the symptoms with which the patients presents mostly with the manic episodes are the we will see the list of those symptoms. But an overly joyful or excited state, overexcited state, is called a manic episode, and an extremely sad or hopeless state is called as depressive episode. Sometimes a mood episodes include the symptoms of mania and depression. You may find the mixed symptomatology, and it is called as the mixed state. If you look on this slide, on the one hand you are seeing the severe depression. Mood is so depressed, or the person is having depressive symptoms. On the other hand, the person is having mania or hypomania, and in between is the normal or balanced mood. Hypomania is the lesser degree of mood disturbance, in which, although that person is having joyful mood, overactivity, and overexcitement, but those symptoms are not so intense that his or her occupational or functional life is being disturbed. Means, although that person is having low symptoms of mania, but these are not going to cause damage to his occupational or social life. उसमें ये होता है कि वो घर वाले दूसरे लोग तो फील करते हैं कि ये आजकल बहुत ज़्यादा खुश है, बहुत ज़्यादा है, तेज़ है, लेकिन वो इतने नहीं होते कि उसकी जॉब पे या उसके उन जो सोशल लाइफ है उसे डिस्टर्ब कर रहे हों, बल्कि वो पेशेंट जो है बहुत ज़्यादा प्रोडक्टिव हो जाता है। उसका, अगर वो किसी ऑफिस में काम कर रहा है तो उसका बॉस भी उससे बड़ा खुश होगा कि ये आजकल बहुत ज़्यादा काम कर रहा है। Or if you think there is no need to treat this condition, as person is working very adequately and he is happy with his home life, and all people are comfortable with his that state. But the uh, uh, but if you are not going to treat that condition, that person may turn into full blown manic episode, which is very dangerous condition, and it may lead to the damage to his occupational, functional, and social life. Now there is a slide to compare the symptoms of depression and mania. In mania, if you look at the mood changes, the person may feel high or overly happy or having outgoing mood, and he may develop irritability, agitation, and his mood may be jumpy or wild. On the other hand, in depressive disorder, person may feel empty, helplessness, hopelessness, and lack of interest and energy, including low desire for sex or libido. And related to behavioral changes, the person may talk very fast and jumping from one topic to another topic, which is called as flight of ideas. But there is some logical sequence between the topics. Although he is jumping from one topic to another topic, but he is not totally irrelevant, which happens in the schizophrenia. In schizophrenia, person jumps from one topic to another topic, but there is no logical sequence. But in mania, the person is jumping from one topic to another topic, but their topic is related to the previous topic. So it is called the flight of ideas. And person may have distractibility increasing distractibility and having restlessness and sleeping little. There is decreased need for sleep. Person may feel fresh even after 1 or 2 hours of sleep, and the person may have unrealistic beliefs in beliefs, or it is called as delusion. What is delusion? Delusion means a firm false belief which cannot be shaken with the arguments and which is contrary to the evidence. Person may have delusion of paranoia. Person may have delusion of grandiosity. Grandiosity is the self-importance ideation. Person may think that he is having special powers or special things are in him, and and he can do everything. And this is called the self-importance ideation. Apart from self-importance ideation, the person may have um ideas of increase religious ideation or increase religious inclination, uh, and that person may have impulsivity and impulsive sexual attitude, or he may have ideas of overspending, means charity or spending much money on the petty things and having business investments, जिसको वो फिर उस तरीके से संभाल नहीं पाता. And on the other hand, depression is, I already told in my previous presentation, the person may have low mood, lack of interest, along with restlessness. He may have irritability, but is and his eating, sleeping patterns are also disturbed. Mm, and thinking of death or suicide or attempting suicide is much higher in the depressive illness. Now we come to the types of the bipolar affective disorder. Bipolar affective disorder usually lasts lifetime. Episodes of mania and depression typically come back over time, but this time depends upon the person's stressors, person's personality, and is genetical predisposition as well. For example, some person may have repeated episodes of mania or depression even after 3 or 4 months, but in some person the relapses and remission are having a gap of 4 to 5 years as well. And between these episodes, many people with the bipolar disorder are free of symptoms, but some people may have lingering symptoms. There are four basic types of bipolar affective disorder: bipolar 1, bipolar 2, And what is the difference between bipolar 1 and 2? In bipolar 1, there is the manic or mixed episodes. This they last at least 7 days, or by mania, manic symptom that are so severe that person needs immediate hospitalization. Usually, the person also has depressive episodes in bipolar 1, typically lasting at least for 2 weeks. The symptoms of mania and depression must be a major change from the person's normal behavior. Means that in bipolar 1, the person may have typical mania or manic episode or depressive episode, but there should be the presence of mania at least for once. कम से कम एक दफा उसे mania हुआ हो और फिर depressive episode भी हुआ हो, then it is called as bipolar 1. But in bipolar 2, the person is having hypomanic episode and depression, but he hasn't developed any full blown mania manic episode. उसमें उसे डिप्रेशन के साथ हाइपोमेनिया हुआ हो लेकिन फुल ब्लोन मेनिया कभी ना हुआ हो, then it is bipolar 2. Other type is the cyclothymic disorder or cyclothymia, is mild form of bipolar disorder in which the person have episodes of hypomania, mild episode of hypomania that shift back and forth with mild depression for at least 2 years. It is cyclothymic. लेकिन वो इतने सीवियर नहीं होते कि वो उस मेनिया की कैटेगरी को या फुल ब्लोन डिप्रेशन की कैटेगरी को पूरा करें, लेकिन यह है कि वो बंदा 100% यानी कि नॉर्मल नहीं होगा, थोड़े बहुत उसमें मूड स्विंग्स चलते रहेंगे और वो उस क्राइटेरिया को पूरा नहीं कर रहा होगा जो मेनिया का 7 डेज का है या डिप्रेशन का 2 वीक्स का है. And the other type is the bipolar affective disorder, not otherwise specified. It is diagnosed when a person has symptom of the illness that don't meet the diagnostic criteria for either bipolar 1 or 2. The symptom may not last long enough, or the person may have too few symptoms to be diagnosed with the bipolar 1 or 2. However, the symptoms are clearly out of the person's normal range of behavior. And this slide is showing the graphical presentation of the patients with bipolar illness. If someone is having bipolar 1, you can see there is a high rating on the graph, and in the bipolar 2 it's less than the bipolar 1, and one state is the cyclothymic personality, and the normal wave pattern is also showed, which is showing a baseline. Now we come to the etiology of the bipolar disorder. What is the etiology of bipolar? Experts believe that bipolar disorder is partly caused by an underlying problem with the balance of brain chemicals called neurotransmitters. First of all, if we talk about the etiology, we should categorize it into according to the biopsychosocial model: biological, psychological, and social factors. In the biological factors, it has been seen that there is over dominancy of dopamine neurotransmitters in the patients with mania. Means whenever there is the increased level of dopamine, person may develop manic episode, and decreased level of serotonin, deficiency of serotonin, lead to the depressive episode. If we talk about the genetical predisposition, it has been seen the heritability estimates for the bipolar illness is about 70 to 80%. So there is a strong genetical predisposition, and the bipolar disorders tends to run in the families. Children with a parent or siblings who has bipolar disorder are 4 to 6 times more likely to develop the illness as compared to the children who do not have a family history of bipolar disorder. Studies of identical twins have shown that the twins of a person with bipolar disorder doesn't always develop the disorder, but results suggest that the factors besides genes are also at work. It is likely that many different genes and a person's environment is also involved. Environment means there are different psychosocial factors. Now we come to the psychosocial factor. The psychosocial factors for the depression and mania are same. As I already told in my previous lecture, early environment means parental deprivation or death of parent, childhood psychological traumas, physical abuse, sexual abuse, or migration means moving from one place to another place. It is the early environment and early environmental stressors. The other psychosocial factors include the life events, means death of close family members or separation or divorce among the parents and uh, loss of job or change of school. All these are the life events. Poverty, unemployment, financial and housing difficulties, low educational status, law and order situation, which is very critical in our culture as well. Social injustice, इंसाफ का ना मिलना, इंसाफ के लिए धक्के खाना, larger number of children, unequal distribution of roles, sensitive, anxious personality traits, and overloaded schedule. Who is at risk? किसको होता है ज्यादा bipolar? Apart from the psychosocial factor which I explained, there are certain personality traits as well. The persons who are anxious, avoidant, or having introvert or obsessive personality traits are more prone to have bipolar affective disorder, including depression or mania. It develops in late teens or early adult years. अमूमन bipolar illness early adulthood में या late teens में होती है and at least half of the cases start before the age of 25, and some people have their first symptoms during childhood while other may develop symptoms in late in life. But you are going to rule out the neurological causes as well. For example, if someone presents to you with the symptoms of mania after the age of 40s, you should rule out the organicity, means organic or neurological or medical causes, because it's very unlikely to develop manic episode first time after the age of 40s or in middle age or in late age. If someone presents with the manic symptom after in old age or in middle age, you may think about the frontal lobe tumors. Frontal lobe tumors may present with manic symptomatology, and you have to rule out the frontal lobe tumor by getting MRI brain or CT brain. So, but if someone presents in the early adulthood or childhood and he is typically having manic symptoms, and if there is a strong family history of mania, then there is no need to get MRI or CT scan. Seasonal affective disorder, actually, bipolar affective disorder is also known as the seasonal affective disorder, in which the person is vulnerable to changes in mood because of sunlight, especially in the spring or winter season. And as weather changes, person may develop mood swings. What is the prevalence of bipolar affective disorder? Lifetime prevalence among 14 to 18 years old is 1%, and subsyndromal symptoms are present in 5.7% of the population. Mean age of onset is 2 to 10 to 12 years, but mostly the patients who are diagnosed with the mania are of the age below than 25. First episode is usually depression, but it has been seen female mostly present with the depressive episode first time, and the male usually present with the manic episode first time. What is the epidemiology? Bipolar affective disorder affects men and women equally, as well as all races, ethnic group, and socioeconomic classes. Bipolar disorder often develop in a person's late teens or early adulthood. At least half of the cases start between before the age of 25. However, some people have their first symptom during childhood, while others may develop in the later age. Peak age of onset is 15 to 19 and 20 to 24 years. As I already told in my first slide, uh, the age of onset is mostly mean age is 10 to 12. But in this is different from the mean. Peak and mean there is some difference. Peak age is 15 to 19 years, and earlier onset and more severe cases in the substance users. Substance users are more prone to have mania or schizophrenia, and especially the cannabis users, church users, are more prone to develop mania or schizophrenia. In early onset patients, typical time lag is 3 to 10 years between the first presentation and initiation of the treatment and hospitalization. मीन्स के 3 से 10 साल तक वो इधर उधर धक्के खाते हैं पीरों फकीरों के पास या अपने तौर पे रेमेडीज करते रहते हैं और उसके बाद जाके ये अमूमन फिर हॉस्पिटल प्रेजेंट करते हैं ये टाइम लेग है टिपिकल टाइम लेग है लेकिन कभी कभी ये भी होता है कि if someone is having severe degree of manic episode the family may present that case to the hospital very soon. Later onset in association with other conditions are associated with endocrinopathology or neurological or medical issues. As I already told, if someone present after the age of 40s, you should think about the frontal lobe tumors. You may think about the hyperthyroidism as well because there is a thyroid mania, the term thyroid mania, which is related to the hyperactivity of the thyroid gland. So you have to rule out the other medical causes as well. Even a mania which is precipitated by the stimulants, drugs, or it may precipitate with the cannabis, chars, and LSD or Ritalin with methylphenidate. These drugs are notorious to cause the mania, and even antidepressant may provoke a manic episode. So you have to take detailed history related to any use of substance, related to use of any medication such as the anti-asthma drugs are also notorious to cause manic episode, and steroids may precipitate the mania or depression. So you have to take the detailed drug history and you are going to look into the other medical and neurological causes as well. What is the suicide risk in mania? In depression, about 30% of the patients are going to attempt suicide, in which about 10 to 15% complete their suicidal act. But in mania, the prevalence rate of attempted suicide in bipolar 2 and bipolar 1 disorder is similar. It is about 30% to 36%. And lethality of the attempt may be higher in the individuals with bipolar 2 disorder compared with the bipolar 1 disorder. Along with the suicidal risk, there is a risk of homicide in mania as well, because these people are very agitated in the manic state, and they are they may be provoked by the minor talk or minor uh, element which is going to trigger their condition. Now we come to the treatment of the bipolar affective disorder. Like depressive disorder, you are going to select the drug, looking into the certain factors which include safety, tolerability of their drug, efficacy of their drug, Payment means is person or his family is able to pay the cost of treatment. Simplicity of the dosing and need for monitoring of those drugs. And you are going to select the drug according to the height, build, age of the patient, and is considering his comorbid illnesses as well. And now I am going to talk about the medications which are used in mania. In mania, in mania, the typical manic episode is going to respond to the typical or atypical antipsychotics. The typical antipsychotics include the haloperidol, which is also available in injectable form and it is given intramuscularly. And the other atypical antipsychotics are risperidone, olanzapine, quetiapine, and aripiprazole. These atypical antipsychotics are having less side effects in the terms of extrapyramidal symptoms, rigidity, tremor, drooling of saliva are less reported with the atypical antipsychotics as compared to the typical antipsychotic, which is haloperidol. But the atypical antipsychotics are notorious to cause the metabolic syndrome, means hypertriglyceridemia and obesity, hypertension, and diabetes. And atypical antipsychotics are not having these side effects such as obesity or increased propensity to have hypertension or diabetes, but typical antipsychotics are notorious to cause the extrapyramidal symptoms. So you are going to select the antipsychotic according to the height, build, age of the patient, and in mania the person is having agitation, restlessness. So, and if he is having a greater intensity of the symptoms, you are going to give injectable haloperidol. And if someone is having lesser degree of symptoms, then he may be shifted to the risperidone, olanzapine, quetiapine, or aripiprazole. This is the acute management of the mania with the help of antipsychotics and with the help of benzodiazepines. Benzodiazepines are the part of the treatment of manic episode because these are going to calm down or relax that patient, because antipsychotics will take time. At least 2 to 3 weeks are required to have a good effect. Till that time, the effect of benzodiazepine is very important, and you are going to give the benzodiazepines which include clonazepam, lorazepam, or bromazepam. You have to select one from this list and you start benzodiazepine to calm down that patient till the antipsychotics have a good effect. And apart from these typical or atypical antipsychotics and benzodiazepines, you have to select a mood stabilizing drug which is going to keep the mood of that person stable. And मूड स्टेबलाइजर्स की मिसाल ऐसे है कि जैसे आप फ्रिज या टीवी को स्टेबलाइजर लगाते हैं कि ना तेज लाइट आए कि वो जल जाए, ना कम लाइट हो कि वो चले ही नहीं. तो इस तरीके से मूड स्टेबलाइजिंग medications are going to stabilize the mood of that person, and that person is having less tendency to fluctuate in the depressive or manic episode. But choice of mood stabilizer uh, is very important. For example, if you are going to choose the lithium, and lithium is the first line mood stabilizer, but lithium is having a list of side effects. It should not be given to the person who are having renal issues, and it shouldn't be given to the persons who are having hypothyroidism because it's notorious to cause the hypothyroidism, and it may lead to the renal failure in toxic doses. And if someone is having renal issue, then he shouldn't be prescribed lithium salt. And there should be the monitoring of lithium as well. If you are going to prescribe lithium to someone, you should monitor the levels of lithium because high level of lithium may precipitate acute renal failure, and the person may be shifted on hemodialysis. So, lithium should be given in controlled dosage and it should be monitored. Although it's a first line mood stabilizer and it's very effective to deal with the bipolar affective disorder. Other choice is the valproic acid, which is anti-epileptic, but it's having good mood stabilizing properties, and it is also considered as first line, but it's also having a list of side effects such as it is hepatotoxic, it may cause blood dyscrasias, and it may cause polycystic ovarian disease or hirsutism, alopecia. So it is not suitable for the females mostly in their fertile age. In their fertile age, you are not going to prescribe valproic acid to the females because it may it may cause the teratogenic effect as well for the fetus. And in female, the treatment of choice in bipolar affective disorder patient is carbamazepine. Carbamazepine is also anti-epileptic, but it's having good mood stabilizing properties. Other anti-epileptic is the lamotrigine, which is FDA approved for bipolar depression, not in manic state. It should be given to the persons of bipolar affective disorder who is having depressive episode. So it's having good mood stabilizing uh, properties. And it was all about the medications, mood stabilizers, typical or atypical antipsychotics, and benzodiazepines. But you are going to give the antidepressant to the bipolar patient who is having depressive episode at that time. Although the antidepressant may provoke the manic episode, but uh, if someone is giving antidepressant, it should be continued at least for 4 to 6 months to control that depressive symptom. And when the person is stabilized and he is out of their depressive episode, he may be continued on the mood stabilizing drug, which include lithium, valproic, or carbamazepine, or lamotrigine. Apart from the pharmacological intervention, psychological intervention is the mainstay of treatment. But unfortunately, in mania, person is not going to listen you. He is not cooperative in the therapy sessions as he is having high confidence, overactivity, and restlessness, and he is not going to listen the therapist. So the psychotherapy or psychological intervention uh, is incorporated when the patient has recovered and is in listening mode, and it includes the support, education, and guidance to the people with the bipolar disorder and their families. Other psychological intervention is cognitive behavior therapy to deal with the faulty cognition of that person, which are going to precipitate mania or depression. So their issues are listened and they are guided accordingly. And family is also involved in the psychotherapy sessions. They are given the insight towards the person's illness, and actually it is this part of psychoeducation in which you are going to the info care to the patient and family, what sort of illness he is having, why it is precipitated, what factors are going to aggravate it, and what are the etiology and what is the treatment option, and what are the side effects of their treatment. Or apart from the psychological intervention, you are going to deal with the family, a family expectation from that patient. फैमिली की एक्सपेक्टेशन बड़ी होती है कि ये क्यों हो रहा है, ये कब ठीक होगा, और ये आगे कुछ कर पाएगा नहीं कर पाएगा, हमने तो इसे डॉक्टर बनाना था, पायलट बनाना था. So you are going to educate them about their expectations as well. And this was all about the bipolar affective disorder. And if someone is having query, please put your questions on my email ID. Thank you very much. Thank you. And sorry, other treatment option is electroconvulsive therapy, which is reserved for the cases who are having mm, who are not responding to the mood stabilizers or antipsychotics or antidepressant for their depressive episode, and they are having treatment resistance. So electroconvulsive therapy is also treatment option for those patients. Thank you very much.